As you come to the stage, Dr. Azra.
Thank you very much. I'd like to thank QED for inviting me. It's very unusual to have an oncologist come to one of these, but I'm delighted to be here. I graduated med school from Pakistan, and then I went on to the US. And in Buffalo, New York, where I had family, where I landed, before even starting my training in medicine, I was too anxious to cure cancer at the ripe old age of 24. So I went to this institute, Roswell Park Cancer Institute, and on its wall is this saying by James Grace, one of its ex-directors: "If I had my choice between a moonwalk and saving the life of a single child with leukemia, I would never glance upwards." And this seemed to completely epitomize what I had come to America to do. I was very excited. I was very emotionally invested from this moment on. Today, I see 30 to 40 cancer patients in my clinic every week. I also supervise a basic cancer research lab. But I think the most important thing is that to learn about the art of clinical practice, one has to be able to stand on both sides of the bed. So before I go on, I want to say that my own husband, who was the head of the cancer center at the university in Chicago, got the very leukemia that he had dedicated his life to cure since he was 15 years old. And our daughter was 4 years old at the time, and Harvey went through an extremely painful battle for 5 years and eventually died. So, did that experience make me a better oncologist? I don't know, I don't think so, but it changed my perceptions. Everything around me was the same, but my eyes had changed. Let me start by showing you a case of Andrew. In July of 2016, he develops tingling. He begins to exercise more. But then weakness developed, and he was taken to the emergency room where he was quadriplegic within hours. And neurosurgeons only could remove 90% of the 9-centimeter large glioblastoma multiforme, the deadliest tumor known to mankind in the brain. Now, from this moment on, because we did not remove all of his cancer, every one of his treating oncologists, including me, knew that we can do nothing for this patient. Yet what followed? Extensive surgeries, shunt placement, intensive rounds of aggressive chemoradiation, immune manipulation, more chemotherapy, more radiation therapy, more surgeries. And the tumors continued to grow while he suffers every toxicity possible. Alas, we failed Andrew. He died just about 5 years ago. 16 months from diagnosis, he was 23 years old. We failed Andrew. How badly we failed this poor young man. Because not only did he die, he died an extremely painful death. The most painful death imaginable. To me, the most important thing perhaps is that Andrew was also the best friend of my daughter Shehrzad. Andrew was not her boyfriend. Our Andrew was gay, but he was her best friend. There are parents in this room. You know how children's friends become your children, because they're in and out of your house all the time. They traveled all over together in high school and college. He returns from Paris after a year of fashion design, ready to take New York by a storm, and you know the rest. I keep asking myself, was it cruel to Andrew and his family to keep suggesting ineffective therapies which would give him a few additional weeks at best when the writing was on the wall? But what were the alternatives? Should we have suggested no treatment, enjoy whatever time you have instead of vomiting your guts out? But then tumors would have grown and death from cancer is extremely painful. Was honesty even a choice in his case? Because basically what we were telling him is die of cancer or die of the treatment. This is my question. Why are these the only two choices in 2022 for anyone who has advanced cancer? In fact, if you look at the age-adjusted mortality, in 2022, it is the same as it was in 1930 for cancer. These statistics are so bad, I couldn't possibly make them up. Sure, there's an incline and then a decline, but that parallels the rise and fall of smoking. So whatever decline you are seeing is due to anti-smoking, anti-obesity campaigns and early detection by screening measures. It isn't like we have discovered some fantastic new therapies to cure cancer. Now, this happens to be America's longest war, declared in December of 1971 by President Nixon. He said that cancer was going to be eliminated by 1976. 1976 came, Nixon was gone, cancer was still being cancer. In 2021, exactly 50 years later and $500 billion later, even the fundamental questions about cancer remain unanswered. 30 million people have died of cancer since 1971, hundreds of times more than in all the wars combined. Sure, there have been successes. We brought together diverse forces with a single mission, established networks of cancer centers, clinical trial systems, data collection systems, advocacy for prevention, removed the stigma. Women couldn't say in the past that they had breast cancer. The disease had a stigma. At least that got removed. Supportive services came into existence, education of patients and families took place, and research was advanced. Research was advanced greatly, helping patients with childhood leukemia, lymphoma, chronic myeloid leukemia, acute promyelocytic leukemia, melanoma, and a few lung cancers. Then we came up with immune therapies and CAR-Ts. These are all great successes. The problem is that all of them only help 15,000 cases a year, when the diagnosis is 1.8 million new cases a year. We have had a reductionist kind of model. We will find one mutated gene making one bad protein, and we will discover one magic bullet to target and take it out. And this reductionist approach has not served a very, very complex disease to be understood properly. Yeah, sure, there was one success, chronic myeloid leukemia and Gleevec, and maybe another retrospectively, and that seemed to prove the paradigm that yes, genetic mutation is it. Now we just have to find the one mutation in pancreatic cancer or ovarian cancer and come up with the magic bullet. But nothing happened. There were too many mutations. So then we said, okay, we are going to sequence the entire human genome and learn about every gene. 15 years and billions of dollars later, the human genome was sequenced, and there was great hope that we will find and cure human disease with this knowledge. But nothing happened. Nothing improved, even with the human genome sequencing. So the next thing we said was, oh, let's sequence every tumor and try to find mutations. So now the Human Cancer Genome Atlas was developed, and nothing happened with that either. Whole genome sequencing of almost 3,000 samples from 38 cancers through collaboration between 750 institutions in 4 continents. This is a huge study. But the results were published in 6 papers 2 years ago in Nature. And I can summarize all the 6 papers for you in literally one sentence. Conclusion of everything was cancer is too complex. Founder mutations were in 95% cancer, so 5% had no driver mutations at all. They were average of 4 to 5 mutations per cancer. The conclusion was it differs from patient to patient, tumor to tumor in the same patient, clone to clone from tumor to tumor in the same patient. This is the problem. It's just always 10 steps ahead of the researcher. They said, oh, it's unexpected, extremely complex genome. Okay, I want to not sound all doom and gloom. Yes, we are curing 68% cancers that are diagnosed today. That's huge. But remember, the mortality hasn't changed much. Why? Because what are we curing them with? Mostly slash, poison, and burn. Why? This is my question. Why are 95% experimental trials today, 95% fail? And the 5% that succeed, in my opinion, should have failed because they improved survival by a median of 2.1 months for a fraction of patients. This is unacceptable. 90% resources are invested in trying to understand and treat end-stage advanced metastatic cancers, and mostly in mice. This is the problem. And what is the public told? The public is very intelligent, public is very knowledgeable, they read newspapers, they Google everything, and what do they find generally? Game-changing therapies were various cancers discovered, cures for the most malignant tumors, malignant treatments now a reality, in fine print. But who reads the fine print? When you are a general public, you don't have cancer, but you're reading headlines, oh, cure found for lung cancer, oh, cure found for brain tumor. You didn't read in mice. This is what you registered. Until somebody you love or you get cancer and go and find out, there's nothing they can do because it's advanced. And so this is what bothers me. 42% of patients diagnosed in America today are financially ruined completely by the second year. So the public accepts physical and financial toxicities because they're expecting cures. So they pay for it, they mortgage their homes, they lay hostage their next generation's future, hoping that there's a 1 in a million chance they would be cured. Okay, why talk about, even when I wrote my book in total frustration? Look at this headline that appeared in Nature. Nature is the most respected journal of cancer of science in the world. You know that Watson and Crick announced the discovery of the DNA double helix in Nature. Today, Nature enjoys the same kind of prestigious place. Without a paper in Nature, you couldn't get into an Ivy League university as an investigator, for example. So this is the kind of thing. This is 25th October, 5 days ago. What is it they said? Cancer drugs are closing in on some of the deadliest mutations. The protein KRAS mutated in many cancers was deemed undruggable. So when you read this headline, you're excited. And this is not the New York Times, that's a liberal, scandalous sheet that comes out every day in New York. I love it, I'm a New Yorker. I can't have breakfast without reading the Times cover to cover. It's not announced, this is in Nature, look at this. On 12th September, Amgen, that's a company, announced that the latest trial of sotorasib found that it extended progression-free survival. Not survival, guys. This is progression-free survival. There's a big difference between the two. Survival is if you're living 6 months, now you're living 12 months. No. Progression-free survival is that the tumor didn't progress. That's it. You would still die in 6 months. Just that the tumor didn't get larger. So just the progression-free survival, a measure of time elapsed without cancer worsening by 1 month longer than standard chemotherapy. Does that justify the headline? And now look at there. Only 28% of participants treated with that unpronounceable drug responded to it. That's roughly twice the number of who responded to standard chemotherapy, but a sign nonetheless that most people who have KRAS-positive lung cancers will not be helped by the new drug, yeah? Now look at their conclusion. The scientists concluded in the same, please go read it, because I know many of you might think Dr. Raza is just making it up. It's Nature. 4 days ago. Even so, the pace of KRAS research and the pursuit of KRAS targeting drugs has never been so energized, says cancer biologist Durr at the University of North Carolina. The first glimpse of success has shown that it is possible to drug the undruggable KRAS. And now researchers in academia and industry are developing ways to improve their approach. I have never seen this level of excitement and buzz in the entire history of the field. The level now is insane. This is what not just the public who are non-oncologists, but oncologists are being told. Not everybody is an expert on KRAS mutations. So hematologists, oncologists who read it, think of it. The excitement in the entire history. Okay, this is why I wrote the book. Because I got fed up. I'm the one facing 30 to 40 patients every week in my clinic, the Andrews of this world. And standing by them. And in 1977, when I came to America, I was treating acute myeloid leukemia with 2 drugs. We called them popularly 7 and 3, 7 days of one, 3 days of another. Today in 2022, same 2 drugs, 7 and 3. Can you imagine the level of my frustration having the same exact conversations with my patients, young and old, 28-year-old, 21-year-old, 38-year-old, 75-year-old, 80-year-old, same conversation. These are the toxicities, these are your chances, basically you'll be dead. I mean, this is why my message and the summary of the book is right here. Detect cancer early, preferably at initiation in high-risk individuals. The strategy I took in writing this book out of total frustration was to look at everything about cancer through the prism of human anguish. I measure every grief I meet. This is Emily Dickinson. I measure every grief I meet with analytic eyes. I wonder if it weighs like mine or has a different size. I wonder if they had it long or did it just begin. I cannot find the date of mine. It's been so long a pain. I wonder if it hurts to live and if they have to try and whether could they choose between, they would not rather die. This is what I am facing. I'm not just sitting on a bench and patting myself on the back because a druggable target is being drugged. No. So what is the only way that works, the only strategy? When we, Woody Allen says that the 2 words that make human beings happiest in the world are, it's benign. But when we give the news that to the patient that you have cancer, then the second best thing we can say is, but don't worry, we found it early, so we can take care of it. In other words, early detection is important. So why not go earlier than stage 1? Because even stage 1 requires slash, poison, or burn. And I want to get away from those horrendous therapies. So my first message is detect cancer early, study human tissues. I started with studying AML. Within a few years, it was clear to me in my lifetime, this deadly disease will not be cured. So I asked myself, are there patients who are at risk of it? Maybe I should study cancer before it declares itself. So let's look at people who are at high risk of acute myeloid leukemia. And there were a group of patients with pre-leukemia called myelodysplastic syndromes. My idea was to intercept before it becomes that end-stage monstrosity. And so in 1984, now this helped me because I had come from Pakistan. I was a fresh immigrant. Had I been raised in the country with its systems, and my next step would have been to make a mouse model. But I was naive. I said, oh, if I'm going to study these patients, I should save their tissue. So I started banking human tissue, blood, marrow, biopsies, all kinds of things since 1984. And today I have the largest tissue repository in the world, 60,000 samples that have been longitudinally obtained as the patients go through their natural history of the disease, all kinds of samples. Not a single cell contributed by another oncologist. The reason I'm emphasizing it because those vials that are in the freezers, each of them has a poignant story for me. These are patients I had befriended. And so, how sacred are those for me? Because I'm the one doing painful procedures. To this day, I do every bone marrow myself, draw every research blood myself. And it's so humbling when patients say, Dr. Raza, just take whatever you need. Even if it doesn't help me, it will help someone else. This is the nobility of the patient. And how are we returning their trust? Well, now I have performed whole genome SNPs because this kind of large data sets you can't apply for little grants for it. So I got Regeneron, which is the huge company given to sequencing, to partner with me, and Grail to do methylation studies on the entire tissue repository. And the whole idea is that we should be able to trace back by going through the longitudinal samples to the first cell, find out the stress markers that caused it, and hopefully prevent it. What I found is MDS is a clonal disease. What does that mean? That MDS itself has become a malignant syndrome. So how do we cite early events in cancer? Occur to someone that maybe a recurrence. We take care of, kill every microscopic evidence of cancerous cells from the body, and then see how recurrence happens. Because maybe the events at recurrence are going to recapitulate what happens at initiation. Because how do you cite initiation? Stage 1 is already too late. There are hundreds of millions of cells in even a tiny tumor. That's why it's so difficult. So at recurrence, this friend of mine, Ken Pienta, who is the head of urologic oncology at Johns Hopkins, what he did is he created a device in which he put these red and green prostate cancer cells and started growing them, and then introduced chemotherapy. But chemotherapy was introduced in a gradient going from high to low. So this area got a lot of chemotherapy, that area got nothing. Now, I hope this video works. I'll try. This is important because the last slide that is a video will need the same thing. Now, so what I wanted to show you was right here, you see the whole field has become black because cells have died, and there they're growing. The time is up there. Now, recurrence starts with these rapidly moving giant cells. They come out of nowhere. Do you see these giant cells? And it's shocking that all of recurrence, just watch, these giant cells arrive from nowhere, and then they start giving birth to little cells. You see, with time, the whole diamond gets filled with the little cells, which are the cancer cells, and the giant cells disappear. So Ken asked the question, what are these giant cells and why is no one talking about them? Why? Because recurrence seems to start with these fat giant cells coming from nowhere. Well, they've been described actually since 1856. Polyploid, meaning lots of nuclei, giant cancer cells can be isolated from the blood. And their number increases post-therapy. They contribute to resistance and refractoriness to therapy. So progeny of polyploid cells play a fundamental role in tumor growth and metastasis. Now, maybe I'll stand on this side. So I want to show you some of the work that I did in my lab. I was trying to create a mutation in this gene, SF3B1, through CRISPR. So we CRISPRed this mutation using human leukemia cell lines, K562, and we treated the cells with chemotherapy. These are wild-type cells growing in a dish. When we CRISPRed, suddenly you see the appearance of these giant cells. Same thing, wild-type cells growing in the dish. When we treated them with chemotherapy, giant cells appear. And when we studied them closely, the giant cells are the ones that have multiple nuclei in them. And in fact, some of them had up to 32N DNA content. Within one giant cell, 32, 16, 8, huge numbers of cells. One thing we did is we fixated our camera on one giant cell and simply followed it through. What is it going to do? Nothing happens for 3 days, and then suddenly it starts birthing little cells after 3 days. It literally is like a somatic cell pregnancy. What's going on here? We have now cited giant cells giving birth to little cells in so many culture systems. You can see one giant cell. And then after a few weeks, all we see is the little cells. That's when we diagnose cancer. So we missed all the initial events. Meiosis, not mitosis, is something very interesting. Raja Raman, a great scientist, was the first to suggest just recently, 2006, that polyploid giant cancer cells produce daughter cells via amitotic division, and he called it meiosis as opposed to mitosis. The daughters or progeny show a near diploid chromosome. They divide mitotically. Jinsong Liu showed that PGCCs continued self-renewal via endoreplication and keep dividing just by budding. In fact, he took one single giant cell and it showed that it forms tumors in vitro. And this giant cell somehow shows markers of epithelial cells and mesenchymal cells. So epithelial cells are making all the tissues in your body, and mesenchymal cells only make blood cells. So how is it possible that a giant cell is expressing markers of epithelial and mesenchymal cells? We see this, that cancer, in fact, expresses markers, and we call it EMT, epithelial to mesenchymal transition, EMT. No one has an explanation for it. These giant cells are going to be the first explanation. They have increased resistance, and they're literally like a Trojan horse. Why? Because if there's some stress in the body or in the organ, then the organ forces cells to fuse together. And this fusion keeps creating a giant cell. But there are little cells trapped inside it. And when the stress is gone, it gives birth to the little cells. They come out and they populate again. So this kind of, detection, so these giant cells, it seems, are very important. So I asked myself the question, well, what about patients then? Can I detect them in patients? So we could look at blood and see if they are circulating, because as soon as cancer starts, it starts shedding cells and debris into the blood, and you can pick some markers from the blood. So I wanted to capture the first leukemia cell in the blood of pre-leukemia patients, saying, can I diagnose early and intercept? So I started working with the rare cells group at the Pasteur Institute in Paris. Patrizia Patrolini, brilliant scientist, has made this machine called ISET, isolation by size of epithelial tumors. This machine I've had for 6-7 years. So I started passing pre-leukemia and leukemia patients' blood through this machine. It simply has a filter that allows smaller blood cells to go through, but larger giant cells would be trapped. Just a coffee filter type technology. That's what the machine is. And guess what? As soon as I pass them through this filter that you see up there, we started to see giant cells. But they're very rare, like 1 in 50 billion cells. That's very rare. And the small cells here, they are leukemia cells actually, but look at the size of this giant cell, and look how pregnant it looks with all those many, many nuclei inside it. In fact, now hundreds and hundreds of patients that I've studied, the sizes, shapes, forms of these giant cells, so bizarre, and always giving birth to the little cells. This is from human cancers now. Giant polynucleated cells in every solid tumor that has been examined, 5,000 of them. Now I'll show you other people's data. Look at the shapes and sizes of these giant cells compared to the size of a small white blood cell, WBC, you see, the small one, and look at the size of the giant cell and the bizarre shapes and forms of these cells. Oh, so they call this CAMLs, cancer-associated macrophage-like cells. Why? Because they express markers of both cancer and blood, because it's from the fusion. Now, of the top 10 most common cancers, breast, prostate, lung, colon, so on, that have been studied, you can see the percentage. In breast, 95% patients showed giant cells. 5% didn't. Why? Because they're so rare. We are only running 10 cc's of blood. Actually, in this case, 7.5 ml. So if you ran enough blood, you would probably get them in the remaining 5% too. So I had Dan Adams, my colleague who supervised all these studies of 5,000 patients, make a summary slide for me. And it's also very interesting that if you treat a patient for cancer and then see, can you still detect giant cells? If you don't, the people will live forever, because overall survival is practically 100%. If you don't find giant cells after treatment. But if you find them, then depending on the size and the number and the shape, the survival goes down dramatically. Couple of patients. This is a heavy smoker, doesn't have cancer. His blood was run through the machine, and suddenly you see giant cells compared to the size of the small blood cell. Now, this person has cancer because there are giant cells. Where is the cancer? Well, it took 3 years before the cancer made its appearance in the lung, and then it was completely resected, and now he has been cured for 12 years. And this is one of the patients that I'm directly involved with into care. I give my blood every week in clinic to run as a control. Well, this apparent non-smoker, healthy woman, she gave her blood just as a control, and we passed through the machine in 2017 and suddenly find giant cells. Literally the ground beneath my feet seemed to fall because she's a dear friend. Where is the cancer? We did everything possible, PET scans, MRIs, CAT scans, whole body scans. How many times I subjected the poor woman to all kinds of things. Couldn't find the cancer. Until 4 years after giant cells. And they kept increasing, by the way, in number, making us more and more anxious. So we followed her very aggressively, and then the pap smear became abnormal. Endocervical cancer was detected, and now we removed everything with surgery, and now no more giant cells. So what am I really telling you? I'm saying it is possible. The first cancer cell can be detected years before the tumor arises. The first cell is a giant cell. It's polyaneuploid, and giant cells were not detected in hundreds of normal samples. So this is one way of easily finding cancer. In summary, giant cells described for 200 years, polyploid giant cancer cells found in both liquid and solid tumors, increase in number after therapy, implicated in resistant, aggressive, metastatic disease, associated with diagnosis, prognosis, progression-free survival, and overall survival. They are good therapeutic targets. Why not take them out at the first cell level? Here's what I'm saying is that there's some kind of stress. Let's say there is an infection in the liver with hepatitis B virus. Now, tissue cells start dying, and they are given the signal fight or flight. Either you're going to develop a strategy to survive or you're going to die. And so lots of blood cells appear on the scene to pick up dying cells. Macrophage comes and tries to eat up dying cells, and cleaning it's its job. But instead of being killed, the tissue cell fuses its genome with the macrophage, with the host cell. And a polyploid giant cell is born. So the first cell is not one cell, it's two cells fusing together. A blood cell fusing with a tissue cell. As soon as that cell reorganizes the genome inside a blood cell, imagine it's doing two things now. One, it can walk out of the organ because it can go and travel in the blood. It's a blood cell. And two, it evades the immune system completely. And those are the two things that have been very spooky about cancer. Always I have felt, how is it possible that only in one disease, cancer, can liver cells walk out of the liver and land in the bone marrow? How? Well, this is how. They are inside a blood cell. These polyploid giant cancer cells express markers of both tissue and as well as blood. Depolyploidization with birth of diploid aneuploid cells I showed you. So this is my new cancer model. Cancer is a stress response gone awry. You know, the model we have been following for the last 50 years is that as cells prepare to divide, they have to double their DNA. During that doubling process, there are DNA copying errors. An error is called a mutation. So with age, as cells keep dividing in our body, we keep accumulating these errors or mutations. And a time comes when there are so many mutations that just one more proves to be the tipping point. That's all very good, but and cancer is a disease of old age. And all this is probably happening, but cancer is very rare. And if this is the case, that the number of times a cell divides makes it more and more susceptible to cancer, then how come elephants never get cancer? And whales never get cancer? Those are huge mammals. They have a lot more cell dividing, so it can't be just accumulation of mutations. I have a different cellular hypothesis, that cancer does not arise out of the blue. There has to be some stress that's causing cells to fight or flight. So one stressed cell meets a second stressed cell and they combine, fuse. And after fusion, there's some reorganization of the genome and the nucleus starts dividing, but the cell doesn't divide. And this is how it becomes a polynucleated giant cell. And then after the stress is gone or decreased, it will birth these cells. Or even though stress is there, it can birth now cells which are able to withstand that stress. Now, when we come in with treatment right now, all we do is we are killing the small cells. We're not killing the giant cell. That is surviving. And with time, that's what causes recurrence. So what I'm suggesting is we should try to have a different strategy. But then it occurred to me, why should I be the only one saying all this? Art is I. Van Gogh can stand and make a starry night by himself. But science is we. And consensus building to me is very important. So what I did is I created an oncology think tank and called up leaders from academia and industry. MD Anderson, Dana-Farber is the Harvard Cancer Center, University of Chicago, Hopkins. You can see top centers in America, and also some of the top industrial leaders. And we held 17 two-hour-long meetings and published an opinion paper that was published in Scientific American. I'm the lead author with 30 authors, with co-authors with me. And we all concluded that we have to find cancer early in the future before stage 1. And so conclusion of the think tank was, try to find the first cell. Well, how are we going to find it? So we concluded that we should identify a group of individuals who are at high risk of developing cancer. Now, there are many such groups, BRCA gene mutations that families are born with, put them at risk, women at risk of ovarian and breast cancer. There are other syndromes, Lynch syndrome, Lou-Ferrigno syndrome. But there is one group that people don't think about. Now, many in this room may have had cancer, or you have someone you love has had cancer. So individual risk is very small, but 1 in 5 new cancers occur in a cancer survivor. So 20% of new cancers that are diagnosed are in a cancer survivor. My husband Harvey had his first cancer at 34. At 57, when our daughter was 4, he had his second cancer that proved to be deadly. 2 cancers were completely unrelated. It's not the recurrence of the same, it's a new cancer. As I said, if you are a cancer survivor, don't get anxious, don't get scared, because your risk, individual risk, is only 13% higher. But when you look at actual diagnosed cases, then, so I said just do the math, because if there are 1.8 million new cases in America diagnosed this year, then 350,000 will be in a cancer survivor. And cancer survivors are connected to the institutions because they keep going for follow-ups and checkups. So I formed the first cell coalition for cancer survivors, including all those 8 institutions. And now we are collecting blood, saliva, urine, feces, hair, and nails every 6 months on 5 to 10 cancer survivors per day at Columbia University alone, where I am. Basically, we are just banking all these samples. We are extending it to all the other centers right now. We plan to collect 50,000 samples within 3 years, and 3,000 of these will develop a second cancer. Now we have run everyone's urine and blood, tested on the filters to trap the first cell. So we have their samples from before and after. All our other samples like plasma, serum, saliva, everything is banked for future use. This tissue bank will be a game changer for cancer patients, because this is how we can prevent cancer. Instead of waiting it to declare itself, we go first to high-risk patients, and once we find, by using multi-omics, try to find the footprints of the first cell using serial samples from my repository. And in the discovery phase, for example, patient has MDS, develops leukemia. We ask the question, who developed leukemia in less than 3 years, who took longer than 3 years? And compared to normal, and we do every omics possible. Proteomics, transcriptomics, metabolomics, glycomics, methylation, genomics, I'm doing this on serial samples. Why? Because to trace back and say, what are the markers of stress I can pick up from 2 drops of blood? At the first moment of diagnosis of pre-leukemia, and say, oh, this person will not develop leukemia for 10 years, we can relax. This person is likely to develop leukemia within a year, let's give them a transplant now. This is possible for 2 drops of blood, never have to do another marrow again. So once we have this prognostic signature, which is already showing amazing results, Then we can go to the validation phase, retrospective, thousands of patients from my tissue repository, and prospectively also. So in summary, what I've told you today is we need to direct more resources to studying cancer initiation, early detection, and prevention. Study human samples, a great need for carefully annotated repositories. We have to find the cells which are circulating, biomarkers for the stress. So the main message is not one of doom and gloom. A very positive future awaits us. Granted, we go from wellness to illness transition point. In fact, we want to call it the welderly, the well-elderly. Prevention is better than cure, and there's an urgent need to focus on first and not the last cell. Let me just end in a minute now by saying, bringing you back to where we started with the case of Andrew. So Andrew's mother, of course, she and I are great friends. She called me the other day, and guess what she said? Now her best friend has the same exact tumor that Andrew had, stage 4 glioblastoma. And the next thing she said to me came like a slap on my face. She said, but Azra, I told her, I said, don't worry, it's been 5 years since our Andrew died. I'm sure Azra has made great progress. How ashamed I feel, how embarrassed we should be. The question I keep asking, how many Andrews have to die before we wake up and realize that if we keep doing the same thing over and over, expecting different results, that is the definition of insanity. I showed you what Nature published 2 days ago. Keep going after mutation, mutation, mutation. Let me end with this little video. Somebody may have to run it for me just to show you.